Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. William Taylor. You've been here before and you're back again, and you are a pediatrician with Chesapeake Pediatrics and Adolescents, and you have an office in Salisbury and now in Berlin. And I appreciate you taking time out of your busy schedule to come in here and talk about a very common medical condition in children. We're going to talk about childhood asthma.
Very good.
So thank you again, and let's get started with a description of asthma and why it happens.
Okay. Well, asthma is a very, very common childhood illness, and many times it's triggered by a viral infection. So a lot of young children will develop a disease called RSV, respiratory syncytial virus, or human metapneumovirus, where they'll wheeze very early on and then they'll continue to wheeze after that. If they've had wheezing for 3 occasions in 6 months or longer, they will get a diagnosis of asthma. Now, a lot of young children will quote unquote outgrow their asthma. By 4 or 5, they're no longer needing medication, and essentially they've outgrown that. It's a subset of asthma in children. There's other people who, there's other children who have a strong family history, but typically you're not seeing asthma present itself in that fashion until 1 or 2 years of age. But the trigger from an infection is very common, and it gives parents a lot of hope to know that only a few of those children will go on to continue to have asthma after age 5.
But we're going to focus more on the ongoing asthma for this program. So how prevalent is that type of asthma?
Well, asthma appears to be about 10%. About 1 in 10 children will have asthma. And it can present itself very young. It can present itself later. The later the presentation, often the worse the asthma might turn out to be.
When you say later, what age are you speaking?
Some children present at 10 or 12. The ones who present early adult is a much more serious asthma usually.
So we'll focus on the childhood version. So maybe just tell us a little bit about what's going on physiologically with asthma.
Physiologically, we're taking in air all the time, and there's certain irritants that we take in. It can be smoke, it can be viruses, it can be things of that nature that will irritate the lung. And we had talked about the viruses earlier, and that sets up an inflammation in the body. And typically asthma has 2 components. It has the inflammatory component, which causes red. You can think of your nose when it gets irritated and you have a runny nose. That's kind of what happens in the lung. It gets irritated, mucus is produced, and when it gets irritated, the small muscles in the lungs that surround the bronchi or the air passages, they get itchy and they want to constrict. And that's what happens in asthma. So in the past, the idea was to attack the bronchospasm, the constriction of the vessels. That was with things like albuterol. Everybody's pretty much heard of albuterol. In the old days, we used to use epinephrine, which was an injection, or theophylline, which was a more dangerous drug for children and adults. And we would attack that bronchospasm. And in the 90s, they started noticing that there was an inflammatory component, and they came up with, they knew that oral steroids would work, but the oral steroids were very dangerous in long term. They affected bone growth, they affected height, they affected a lot of issues, especially in young girls. So when they came up with the inhaled corticosteroids, they were able to attack that inflammation, and if you attack the inflammation, you're not getting the bronchoconstriction. So the whole idea now with asthma is preventing the bronchoconstriction by attacking the inflammation with the inhaled corticosteroids. And when people hear the word steroid, they get a little bit frightened, but I can tell you that Daily inhaled corticosteroid is taking it for 11 years is equal to 1 week's course of an oral steroid as far as how the body sees that, because the inhaled corticosteroid is metabolized right in the lung, and so very little, if any, of that steroid is seen by the body.
It gets into the bloodstream where it can have those long-term effects.
Right.
Well, that's very encouraging. I mean, we've talked about management just coming so far. You know, the medicines and all are so much better than they used to be.
Oh, absolutely.
So we'll get to that later.
Yeah.
But let's talk more about now the risk factors and, you know, the allergy piece, the genetic piece. You know, how does that all come together?
Well, there definitely is a genetic component. When we have someone come in and they're wheezing, we always ask, is there a family history for asthma? And it does, you know, and sometimes we have to ask the question, does anybody wheeze? Because, you know, some people think that there's a stigma of having asthma, and they say, well, you know, I use an inhaler once in a while, but I don't have asthma. But if you're using an inhaler once in a while, you probably do have asthma. There's just so many different forms of it, and there's very mild asthma and there's very severe asthma. So a lot of people who, you know, maybe in their 50s or 60s, they were told they had chronic bronchitis. Well, that is asthma. It's just 50 or 60 years ago, there wasn't much you could do about it. So doctors were reluctant to put that label on somebody because they would be very upset and maybe, you know, not know what to do about it. In the old days, we used to, but before my time, they used to give Ipecac, which actually would cause vomiting. And the vomiting actually caused bronchodilation and would give you some relief from your asthma. So we've come a long way
yes.
from that time.
I still remember those old Primatene Mist commercials.
Yep.
And just treating attacks per se. You know,
Right.
you just kind of wrote it out, played a waiting game, and then if you had an attack, we addressed it very aggressively. But so now, we'll get to it. It's just really impressive,
Right.
the management of it now, where it's not nearly as scary as it used to be. Any other risk factors?
Well, you know, certainly premature babies are at higher risk for asthma. Babies who'd been on a ventilator are at higher risk for developing asthma because they've had an insult to their lung. They've had some damage, minor damage to the lung. Children who develop RSV, which is respiratory syncytial virus, at an early age, they're also at risk. As many as half of them, as many as 50% of them will develop asthma. Now, as I said before, they might develop that asthma, but by 5, they're not wheezing anymore. So there is hope for those children. And there's some children, though, that they have a strong family history, they're going to it's definitely going to trigger their asthma, and we'll treat them.
And what about the allergy piece? I mean, not all kids with allergies have asthma, but it is a component for some people.
It is a
for some
component.
children.
Asthma has triggers. And just like, you know, people who had a food allergy, that's your trigger and you develop hives. Well, children and adults too, they may have a trigger. It might be hay fever. It might be dog. It might be cat. It might be dust mites. It could be just house dust. There's a number of things that are triggers to children's asthma. I recently had a young boy in the office, and you know, he was on medication for asthma and allergy, and he just looked terrible. And I said to Dad, when is he worse? He said, when he wakes up in the morning, he's the worst. I said, I think he's got a dust mite allergy. And we had him dust mite proof his bedding. And he came back 2 weeks later, and Dad said it was a miracle. He was so much better. So just little things like that. If we can decrease our trigger, if we know what we're allergic to and avoid it, we may have less trouble with our asthma. Obviously, keeping away from smoke, and most likely keeping away from people who are vaping. I think both of those can be triggers for asthma.
Smoking and vaping, you know.
Yeah.
So you mentioned wheezing, and wheezing a certain number of times that persists for over 6 months is a diagnostic criteria. What
Yes.
other types of symptoms should parents be on the lookout for in the development of asthma?
Well, there are some children who just cough at night. They have persistent cough every night. They cough at night. And they may not even hear them wheeze. Sometimes that is an insidious little form of asthma. It's called nocturnal asthma. There's also, you know, people who've never wheezed, but they have a bronchospastic cough. You've never heard them wheeze, but if they go to the allergist and have pulmonary function tests, they actually have some bronchoconstriction, and then when they take the inhaler, it clears up their bronchoconstriction. Even though if you listen to them, they're really not wheezing. So there's also a mild form called exercise-induced bronchospasm, and we see that a lot in athletes, and we see that in people who've had asthma early, and then later on, all they need is a couple puffs of their albuterol before they go take a mile run, and they do fine.
So if a parent sees signs such as the wheezing, although it doesn't have to be very overt wheezing, and coughing, particularly at night, you know, or they just seem to get respiratory infections more than the most, is that another?
They definitely are going to get respiratory infections that tend to go to the lungs. So they're more prone, children with asthma are more prone to get pneumonia. They tend to get bronchitis more frequently, although that's usually a viral process. But anything like that is going to trigger their asthma. So I think that a non-sedating antihistamine is a good component of good asthma care.
I guess a flu shot on an annual basis would be very important.
Flu shot is extremely important and could be life-saving. The other thing, too, is once you get into the persistent type asthma, because there's intermittent asthma, that's a child who might get a cold once in a while. He'll wheeze for a couple days. He'll get better. But the children, once you're into the persistent asthma where you're having, you know, two or three times a week you're needing your inhalers, or, you know, you're having daily need for your inhalers, obviously, at that point, they're on an inhaled corticosteroid, something like Flovent or Pulmicort or Qvar. These are names that people are probably fairly familiar with if you have asthma. And they probably should be allergy tested, because if you can find out what your trigger is, you can avoid it. And then, you know, the worse your asthma is, the more likely going to an allergist, getting tested, and possibly even having immunotherapy, the allergy shots, the dreaded allergy shots. The worse you are, the more likely the allergy shots are going to make your asthma a lot better.
Well, that's good news then. Now, before we get into the management and treatment and so forth, what are some of the reasons why it's so important to treat and manage asthma in terms of complications? What we're trying to optimize lung function or prevent long-term damage?
Absolutely. So we're trying to basically reduce long-term damage to the lung. And the more bronchospasm you have, the more asthma attacks you have, the more likely you're going to end up having some permanent damage to the lung, where there's a permanent narrowing of the airways. And that has to do with that chronic inflammation around the bronchi and the lung. And after a while, that gets a little scarred down, and then you don't have quite as much elasticity of your lung. So the take-home message is if you've been asked to take an inhaled corticosteroid, such as Flovent or budesonide, which actually can be in a nebulizer, or Qvar, or any of the number of ones that we prescribe, take it until you're told not to take it. It's important to keep taking it, because I like to use the analogy of a forest fire. When the forest fire is there and the plane comes in and drops the water, that's the albuterol. That's the short-acting beta agonist. It lasts for a few hours, but then the fire comes back. When they come in and put that red stuff on, the fire retardant, that's like the Pulmicort or the inhaled corticosteroid. That'll protect you from wheezing for the next few days. But if you stop taking it, 3 or 4 days from now, you may start wheezing again. So it's important that you take your medicine just as prescribed by your physician.
Well, you've sort of gone into it. So talk about the difference between, you have these short-acting medications that are helping with bronchodilation, and the longer-acting ones, and then you mentioned a nebulizer, which we were talking before the program, and
Right.
You're saying how that has dramatically enhanced treatment.
Dramatically. When I was a resident, we used to give injections of epinephrine. We would give 3 in a row, and then if they were better, we would give them a long-acting one called Susfrin and send them home. There wasn't any nebulizers at that time, but by the time I was done with my residency, within a 3-year period of time, we were giving the nebulizer treatments in the emergency room. And then later in the 90s, we started sending nebulizer machines home. with patients, and that was revolutionary, really. It gave parents a lot of control at home, that they could keep their children under control without having to keep running to the emergency room for shots. So, so that really revolutionized everything at that point. And now with the nebulized inhaled corticosteroid, budesonide being the one, which is also called Pulmicort, we can give this to even small babies twice a day, and it really keeps their symptoms minimal or not present at all.
Without the more serious systemic side effects that people think of with steroids.
Exactly. So those are very, very safe. We always recommend that, especially young children, use a mask so it doesn't, nebulize into their, or their eyes. And then the other thing would be is to wipe their mouth after a nebulization. And if you can, older children, to make sure their mouth is washed out, because it could cause thrush.
So that is how we're managing it with the steroids. What about the little inhalers?
Yeah, so the short-acting beta agonist would be like albuterol. And then the next step you would go to would be the inhaled corticosteroids and or a drug called montelukast, which is called Singulair. People probably
see that
know
advertised,
that.
yeah.
It's a very nice medication. It comes in a chewable. It comes in a powder for little children. Usually by 2 or 3 they can do the chewable. It has a nice flavor to it. And they take it at bedtime. And it's a leukotriene modifier. And it really does have a beneficial effect. Not on everybody, but it does help a lot. I think it's very helpful for exercise-induced bronchospasm. And it's been shown in some studies if you take it 2 hours before, let's say, a soccer game or a track meet, it does affect a positive outcome for your asthma. So there is also called a long-acting beta agonist, which is called a LABA. That is, there's formoterol and salmeterol. And those medications, they keep your lungs clear all day and all night. But there were some studies that showed that if they were used alone, that there was a slight increase in death with them. But they have combined those medications with inhaled corticosteroid, and there's been no deaths reported with them combined between the steroid and the long-acting beta agonist. So you'll always see them together, like Advair or Symbicort. Those are the 2 most commonly used. And that's another step. And once your asthma gets better, your physician might cut you back to just the steroid. And then if your asthma gets better, you can cut back to just the, maybe just the montelukast and your short-acting beta agonist. You can always take your short-acting beta agonist.
So it sounds like there's a lot of options and ways to address it that are fairly safe now, that are
very safe. And prednisone is still used. We still use prednisone pills. We use the prednisolone in the little children. And that's when you're in a situation where someone comes in, you give them 2 or 3 nebulizer treatments with albuterol in the office, and they're just not, you're not sure they're going to turn the corner with that alone. You'll put them on oral steroids just to break the bronchospasm, strongly decrease the inflammation in their lungs, prevent a hospitalization. And that's what we do in the office.
Well, that's always good news if you can keep a child out of the hospital, right, and take care of it in the office or at home.
It is one of the most common causes for hospitalization these days. So PRMC sees a lot of respiratory issues on the pediatric ward and the emergency room.
And you're saying, especially here on the shore, we seem to be a hotbed for allergens and triggers and such.
Yeah, as many as 85% of people on the Eastern Shore have some form of allergy.
Well, very good. It sounds like there's a lot of newer developments now with the management of asthma, making it, not nearly as problematic as it used to be. So let's talk about if there are any prevention or any other tips you want to emphasize about management of asthma.
Well, I think once the diagnosis is made, I think it's important that the medications are taken just as prescribed, and that at follow-up visits, we make decisions as to going on more medication or higher dose of inhaled corticosteroids because there's low, medium, and high dose. Or if we're doing really well, or if it's a good time of year for you, we might back down a little bit on the medication. I think it's important to, take your antihistamines at the time of year that seems to be bothersome to you. Staying away from, as we said before, the smoke, the vaping, the allergens that are bothering you. I had a boy one time who he had a dog allergy, and if he just stayed away from Grandma and Grandpa's who had the dog, he was fine, and he didn't have the asthma or the allergy symptoms.
And then this is a message to parents is they're going to oftentimes have to manage those situations. You can't have dogs, or they shouldn't smoke or vape around their children is important there. If you're talking about pediatric cases.
Very important.
And of course, getting the annual flu shot. And of course, how often would a child with asthma be seeing the pediatrician? I know most kids go once a year.
Well, usually, children with asthma are going to be seen probably at least every 6 months. I think children who are on inhaled corticosteroids are probably going to be seen about every 3 months.
Okay.
Ideally, it doesn't always work that way, but that's ideally what we should be doing, because there's 4 seasons, and each season seems to have its own challenges when you have asthma. Summer seems to be better for most children. Winter, you have trouble with the respiratory infections triggering it, and then you've got the spring and fall where you have the allergy seasons.
Right.
So.
Well, it's good news though that we have advanced treatments and management of this. That it's nearly not as problematic as it used to be. You said a lot of people live normal lives; they can participate in sports and things.
Absolutely. In fact, about 10% of professional athletes have asthma. So I tell my patients, parents hear that diagnosis and they're usually a little bit disturbed about it, and I let them know 10% of professional athletes have it. Your child should be able to do anything that any other child does as long as they take their medicine. And the good news is there's a good percentage of young children by age 4 or 5 are no longer wheezing, and there are about 40% of children who are still wheezing at about 10 to 12. Once puberty hits, 40% of them will go into a remission. We call it remission because we know that they usually will start wheezing again when they're about 45 or 50.
Well, some good news there to end on, and of course the importance you wanted to emphasize of parents making sure they take their medications at least till the next visit, or don't just discontinue them because they seem better. Those medicines are working to keep them in good shape. Right.
One other thing I wanted to add, every patient who's on inhaled corticosteroids should get an asthma action plan. So it's a little paper that is in triplicate that you can give to the school nurse, and it has the green zone, the yellow zone, and the red zone. And the green zone it tells you what medicines you're taking to keep you under control. The yellow zone shows when you're starting to wheeze or get into trouble, what you do to get yourself back into the green zone, and then the red zone tells you what to do when you're in trouble. And then that's, call 911 or call your physician and get some help.
Well, that's very helpful. It sounds like there's a nice system in place.
There is.
I thank you so much for coming on the program to talk about this very important topic. And we'll post some websites that you recommend at the end of the program where our viewers can get more information.
Well, you're very welcome. Thanks for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.